So disturbances of fluid and electrolyte balance include dehydration and fluid overload. I introduced dehydration and the importance of monitoring for it in the last lecture, but we're going to dig in a bit more here and talk about the different types of dehydration and how we treat it. So dehydration is very common and is encountered when total output of fluid exceeds total intake. Dehydration can occur from inadequate intake as well, but often will occur with abnormal losses such as illness, burns, diabetic ketoacidosis, sepsis, and most commonly gastroenteritis, resulting in diarrhea and vomiting, which we will also talk about a bit during this lecture. So since sodium is the major osmotic force that moves the fluid from the different compartments, we often talk of dehydration according to the plasma sodium concentrations. Students sometimes have difficulty remembering which is which, so I'll provide a few visuals. So isotonic is the most common type of dehydration in children where you have equal amounts of water and sodium loss. And so how do you remember this? If you are not a prefix person who already is aware that iso is equal, then you can think of iso is I so perfect. Okay, so you have this equal loss of water and sodium. There's no redistribution, and the majority of fluid is lost from the extracellular spaces. So if fluid is lost from that area, what do we think then happens? What are we going to see? Decreased plasma volume, right? Decreased circulating blood volume, which leads to low blood pressure. You'll see effects on skin, muscles, and kidneys as the blood shunts to the most vital organs like the brain and the lungs and the heart. So our biggest threat here is shock from hypovolemic shock, okay? And we will be treating this with isotonic normal saline. Now in hypotonic or hyponatremic dehydration, the electrolyte deficits exceed the water deficit, okay? So your intracellular fluid is more concentrated than your extracellular fluid, so water follows the solutes into the ICF to establish that equilibrium. As a result, that cell swells up like a hippo. Hippo, hypo, okay? So we've got that swelling or loss of sodium and excess of water. Okay, the serum sodium levels in this case are generally low because it is all moved inside. And so we're looking at less than 135 for serum sodium levels. And hyponatremia. Hypertonic, you can think of a hyper person running all over, so being generally thin. This type of dehydration results in water loss that is in excess of sodium, resulting in hypernatremia or greater than 150. Now this is the most dangerous type and often occurs in infants with diarrhea who are given fluids, PO, with like large amounts of solutes. The extracellular fluid volume is greater and seizures are likely to occur with high sodium levels. So management of dehydration takes a few things into consideration, primarily the type of dehydration and the degree of dehydration, so that we can intervene properly. And this all comes down to our assessments. So what does that entail? Well, as a nurse, you need to complete and pay attention to 4 major components of your assessment that can indicate the hydration status of your patient. Okay, so what are those? Well, we have our physical assessment, right? Looking at things like skin turgor or cap refill or their mucous membranes. We have body weight, which is actually a really huge indicator of fluid balance. We have their intake and output. What are they drinking? What are they losing? What are they getting through IV? What are they throwing up? Okay. And then we also have laboratory data. So what would you be assessing to look for signs of fluid deficit? Well, is their skin tenting, right? Are they making tears? Are the mucous membranes sticky or are they wet? If they still have a fontanelle, is that one sunken? How is their output? Thinking about that as well, now we're looking at signs of decreased circulating blood volume. Okay, so what would you see if their blood volume was decreased? Well, they would have a high heart rate, right? They would have a prolonged capillary refill. Their blood pressure would be low, okay? In general, you can estimate the lowest tolerable blood pressure by using that same formula that appeared in the week 1 lecture, which is 70 plus 2 times their age in years. So what about intake and output? Okay, minimal acceptable output is very important. We need to be able to identify when a patient isn't having enough output during our shift so that we can get ahead of that before it becomes a problem. So this requires calculating all sorts of intake. Fortunately, the EMR does this for you, but it, thinks about your IV intake, your enteral intake, your PO intake, and then all sources of output, including if you have an NG to suction or any drains or any emesis. One of the most important determinants of the extent of dehydration is body weight. It's what we often use. And before I jump ahead, I did realize that on that last slide, I had the calculations for adequate output. You don't have to have that memorized, but just be aware because you might use it in your day-to-day nursing. So going back to body weight, after clinical signs of dehydration have been observed, then the degree or percent of dehydration should be determined. And so we calculate this by taking their baseline weight, like their pre-illness weight, and then their current weight, and calculating the percent loss. So for example, a 10 kilogram patient who has lost 1 kilo is 10% dehydrated. So accurate weight is really important on these patients, using the same scale, using, taking it at the same time of day, in the same diaper, or clothes or naked, however you do it, it should be consistent so that we are monitoring that weight change, as well as rounding to the 100th to be as specific as we can with that number. Down below here, you can see the ranges for mild, moderate, and severe dehydration. Every 1 kilo of weight that is lost is equivalent to a liter of fluid loss. So it's pretty significant. The degree of dehydration calculated should always be compared to your clinical signs, which may be better indicators of hydration status and are also especially useful when a pre-illness weight is unknown. As far as objective signs of dehydration, they're generally present once your fluid volume loss hits about 5%. So with mild dehydration, you're not going to see a whole lot yet. Okay, they're going to complain of thirst. They will have some decreased urine output, but those clinical signs that we're looking for aren't really showing up yet because they can compensate. Your cap refill, however, may be slightly delayed, but this can also vary depending on your patient's sodium levels. Moving on to moderate dehydration from that 6 to 9%. The earliest detectable sign here is usually tachycardia, followed by dry skin and mucous membranes, sunken fontanelles, and then signs of circulatory failure like cool skin and mottling and prolonged cap refill. I'll leave that up there just for a second because I didn't realize they were going to come up in groups. Okay, as we move on to severe or 10% loss, you see that everything just gets worse, right? The urine stops completely, your pulses are thready, the cap refill is super sluggish. This is where you start to see level of consciousness changes. Lab data are actually more useful when results are significantly abnormal. In dehydration, one component, hematocrit, can be elevated. And so why do you think this is? Because this is actually the most common cause of elevated hematocrit, dehydration, and that's because the fluid volume drops. And so your RBCs, the concentration of RBCs in your blood artificially rises due to that dehydration. Your specific gravity results will be above 1010 and can indicate mild dehydration. The higher the number, the more dehydrated they may be. Basal and metabolic panels will show electrolytes and kidney function. Blood gases can help evaluate acid-base balance, and the serum osmolality can help evaluate the body's water balance. So what can we do for someone that needs additional fluid? Well, fluid therapy. And fluid therapy is initiated for children when they are unable to ingest sufficient amounts of fluid and electrolytes to meet their ongoing physiological losses, replace previous deficits, and replace their ongoing losses. So the solution is selected based on what is the probable type and cause of dehydration. This usually involves normal saline 0.9% or lactated ringers because that is close to the body's serum osmolality as they are isotonic solutions. A more accurate way of describing dehydration is to reflect the acute fluid loss in milliliters per kilo of body weight in the past 48 hours. Since dehydration is usually due to output rather than lack of intake, we can utilize measurements of diarrhea or emesis. So for example, 50 mils per kilo is considered to be mild fluid loss. And while weight is the most important determinant of that percentage of total body loss, usually the pre-illness weight is unknown by the time they come into us, and so it's really hard to estimate this way. Once the degree of dehydration is discovered, then we can look at what type. So then you're going to look at the sodium level, and if it's less than 135, it's hypo. If it's 135, it's iso, and if it's 145, it is hyper. So keep in mind, I'm jumping right into IV therapy here, but as we swing back around and talk about not dehydration, vomiting and diarrhea, and in that mild and moderate dehydration, we're actually going to be using oral rehydration because that's best practice, and you should always start there. It is cheaper, it helps reduce vomiting, and it can be done at home. But since we're already talking about fluids, we're going to jump ahead. So we do this in phases because while it's important to replace these deficits, we need to go slow. In some instances, like severe hypernatremia, if you replace it too fast, you can cause issues like seizures and cerebral edema and convulsions. So those that are in that hypertonic state need to be corrected slowly. So phase 1 is usually when you'll see patients receiving IV boluses. We use isotonic solutions like normal saline or lactated ringers, and we're just trying to increase volume at this point to prevent shock. Then we will move on to phase 2 when we have restored that initial volume. Then we can work a little bit more slowly to partially correct the fluid and electrolyte deficit over about the next 8 hours. And then we will continue to stabilize those electrolytes, but then start to reintroduce protein and calories in the form of regular diet. So our boluses are going to be given at a rate of 20 milliliters per kilo over 20 minutes, and we can repeat this up to maybe 3 times. Blood pressure should improve, as well as any other signs like irritability, decreased level of consciousness, and tachycardia. It is really quite amazing how quickly an IV bolus can turn a dehydrated kid around. We always talk about how they perk up. They'll come to the unit with the bolus going, and within a half hour to an hour, they're a completely different kid. So they really do work quickly and effectively. Our basal maintenance calculations are based on the body's requirement for water in a normometabolic state. This is the calculation here, which you should be familiar with by now. And then you can decrease or increase based on any anticipated losses or requirements. So 2 common solutions that you're going to see in pediatrics are listed above. We are moving now towards D5.9 because they've been noticing trends of hyponatremia with hypotonic solutions like D5.5 and D5.25. It's very important that when you have IV fluids that have added potassium that your patient is voiding prior to giving them potassium. It's really common to see someone come up from surgery with normal saline or lactated ringers and then have an order that specifically says to switch to D5NS with 20 of K after first void. And this is to make sure that their kidneys are actually eliminating those solutes. It's also important to notice that the potassium in these fluids are not increasing a low potassium, okay? This is added with dextrose to help reduce the risk of hypernatremia. It's functioning as a counterweight in these fluids to give a balanced electrolyte solution to the patient. So fluid overload real quick. This is obviously less common than dehydration, but it's important to know in children. Kids that ingest excessive amounts of electrolyte-free water can develop a concurrent decrease in serum sodium that is then accompanied by CNS symptoms. And so this inflow of water will cause the cells, including those in the brain, to swell, and the central nervous system can also be affected. And so symptoms of water intoxication include staggering or loss of coordination, lethargy, nausea, bloating, vomiting, dilated pupils, glazed eyes, excessive salivation. Formula is one of the biggest culprits because oftentimes due to financial reasons, people will dilute their formula. And this is why we say you should not do that because babies are not equipped to handle the free water. Another way that this can sometimes happen is in swimming. Infants might hold their breath and then take a deep breath and swallow large amounts of water that way after repeated submersion. So that can also be a risk factor for water intoxication. So piggybacking onto fluids and electrolytes, we can jump right into vomiting and diarrhea for a few minutes. They're not necessarily disorders themselves, but are some of the more prevalent GI conditions that will show up during multiple disease processes. The biggest concern with this is their contribution to fluid loss and electrolyte imbalance. So diarrhea is a symptom that results from disorders that involve digestive, absorptive, and secretory functions. The inflammation in the gut will cause decreased fluid and nutrient absorption, as well as increased peristalsis. It's often caused by infections and is generally self-limiting within 14 days. However, it remains the second leading cause of death for children less than 5 years of age worldwide. So in the US, despite the many improvements in water treatment, sanitation, education, and medical care, diarrhea still remains one of the most common pediatric illnesses. Each year, children less than 5 years of age experience 20 to 35 million episodes of diarrhea. About 65% of the hospitalizations and 85% of the diarrheal deaths occur in the first year of life. So again, those infants are really sensitive. Worldwide, diarrhea still causes more than 10 childhood deaths per day, so it does remain a significant global problem, especially in areas without access to clean water. Rotavirus is the most common cause of serious gastroenteritis among children, with about 28% of all cases causing fatality, that makes no sense. Causing fatality, sorry, is what I meant to say. It is spread via the fecal-oral route. In areas where rotavirus vaccines are common, though, norovirus is the majority offender for diarrhea. So diarrhea will cause signs and symptoms of, you guessed it, dehydration. So these should all look very familiar now, but this is kind of a more fun graphic than the one from before. So lots of diarrhea can be managed outpatient. So when do we want to see these kids? Well, here is your list. I'm not going to read them all, but essentially underlying conditions, visible blood in the stool, okay? If it seems like they are actually being negatively affected by the fluid loss. And most definitely if you're seeing changes in level of consciousness or they're not responding to oral rehydration, that is when they would need to be seen. The outcome of vomiting is similar to diarrhea in that it causes fluid deficits. So I'm going to really quickly discuss this before we move on to that oral rehydration part. The causes of vomiting are varied and can be anything from GI disorders and infection to tumors or increased cranial pressure or even medication side effects. It's usually episodic and will resolve on its own without intervention, but it's really uncomfortable and really anxiety inducing. Some risk factors include migraines, substance use, head injuries, pregnancy, but it's most often caused by gastroenteritis in that under 5 crowd again. And so we'll treat it symptomatically and focus on the underlying cause if we can. The one thing that I like to emphasize is that vomiting and diarrhea result in different acid-base imbalances. So if we take a look here, they have opposite results. And an easy way to remember is that vomit comes up and diarrhea goes down, and the pH follows in the same direction. So for vomiting, you will have alkalosis or higher pH numbers, and then in diarrhea, you will have acidosis or lower pH numbers. And then the chloride numbers are also opposite in these two conditions. So what is the best way to treat dehydration if it's not IV fluids? It's going to be oral rehydration therapy. If the patient is mild to moderately dehydrated, we can use Pedialyte. All of the main governing bodies here in healthcare recommend ORT as the treatment of choice. It is more effective, it is safer, it is less painful and less costly. And so the key is to really catch dehydration early and start this as soon as you can. Oral rehydration promotes the reabsorption of sodium and water. It reduces vomiting and the need for IV solutions. So it is given based on just how dehydrated they are. Okay, you don't need to memorize this. Just be aware. We can also give Zofran to help assist with tolerance, but for those kids that do refuse to drink or who keep vomiting, we can start giving like 2 to 5 mils via syringe every 2 to 3 minutes until they can handle more and just kind of increase as tolerated. And the idea is if you're giving it that frequently, you're eventually going to give more than what they are losing and they will start to tolerate it better over time. So after the initial rehydration, we can still use ORS, okay? They can take it while they are doing their regular diets. Any ongoing stool losses should still be replaced on a 1-to-1 basis with that ORS, even if they're starting to eat, but refeeding can begin within the first few hours with complex carbs, soup, things like that. The brat diet is no longer recommended. It has little nutritional value and it can actually delay recovery. So as long as we're doing complex carbohydrates, nothing that is too high in fat or too sugary. Milk usually isn't well tolerated, but most foods actually work very well. Antidiarrheals should not be used because, once again, we don't want to use symptomatic or symptom preventing medications in kids. So this concludes the lecture on fluid deficits, just under 20 minutes. I tried, guys. Have a great day.